Dr. Crystal Pollitt's with us now, so that's fabulous, and I'm sure she's very busy too, like many of us. Uh, and Dr. Crystal Pollitt's going to talk about the passive air sampler to assess personal exposures to SARS-CoV-2. I'll just give you a bit of background with Dr. Pollitt. So her research explores the human exposome through characterization of environmental and biological samples using analytical and mass spectrometry techniques. Her group has developed various mass spectrometry, ICP-MS, LC-MS, and GC-MS to measure exposure to complex mixture of trace elements and organic compounds. She's applied these exposure assessments in methods in numerous epidemiological studies. And I'll just quickly give you a bit of background where her studies have been. So she has a BSc from the University of Toronto in chemical engineering, interestingly enough, a Master's of Science from the University of Toronto in chemical engineering, and she's got a PhD in King's College London environmental toxicology, which is really interesting as well. And I think Marianne Levitsky may be on. I saw Marianne in the list of participants. I think it's Marianne. So we belong to Workplace Health Without Borders as well. And just some of the work, you know, that you've been involved in, the Mudra study in India, assessment of indoor biomass smoke exposure, induced adverse respiratory outcomes in women and children living in rural regions of India. The Shunyai birth cohort in Beijing, personal air pollutant exposure assessment of pregnant women. And there's also a project looking at household air pollution and immune function in South African children. So it's really great to sort of get to know you about and see this wonderful international work you're doing. And you hopefully, with Workplace Health at the Borders, you might be able to share some of that in the future. But I kind of detract. So I just going to hand the reins over to you, Dr. Pollitt, and just talk about this novel sampling technique. Over to you. Thanks again.
Thanks so much for that introduction, and thank you so much for the invitation to speak. It's always so lovely talking to you, Kevin, and the rest of your group here. And as was mentioned, a lot of my work focuses on being able to better understand the different environmental exposures that we're exposed to. Much of the work has been looking at environmental chemical exposures, and we've pivoted during COVID to expand our environmental factors of interest to look at respiratory viruses, and have modified the tools that we have used previously to be able to do this. And the series of speakers today really leads in well to what I'd like to share and focus on air, and thinking about how we can use environmental matrices as a tool for surveillance and being able to track exposures. And we've realized this as we've gone through the past 2 years, and we have just a persistence of COVID cases. And now as we start to see masking requirements, especially in the US, starting to be lifted very recently, we really need to be better to be proactive and understand what case levels are, and using environmental surveillance is an attractive method for doing this, be it through using the sewage samples, as the previous speaker talked about, as well as using air samples, as we know that this is a respiratory virus, and many of us on this call have known that airborne transmission is an incredibly relevant route that is now acknowledged to be important when thinking about our risk of transmission. Given that much of my work is focused on being able to monitor the air, the extension to being able to using air monitoring devices to identify viral exposure is one that I've been lucky to be able to partner with a number of groups at Yale to do. There are, however, challenges when we're monitoring the air. By being able to monitor levels in the air requires to be able to have great sensitivity, because we're dealing with very low levels of viral levels. So if we were to take do viral monitoring in a nasal swab, we're dealing with thousands of viral copies, and the detection tools that we can use for it don't require as much sensitivity as if we're dealing with just a couple RNA copies, a couple hundred RNA copies that we would potentially be exposed to in the air. So we need to rethink the ways in which we collect viral material, especially if we want to look at viable viral material, and also the sensitivity of tools that we're using. And I list here a recent opinion piece from the New York Times that came out about a month ago that highlights the need for this environmental surveillance techniques. So the ways in which we can look at transmission of droplets of aerosols primarily has been limited to using surface swab samples where there may have been deposition. A lot of this has been though focused on fomite transmission, which was relevant, we thought, early on in the pandemic, realized that the relevancy is limited compared to other routes of transmission, and also challenges just at looking at fixed locations if we're dealing with swab sampling, looking at exposure. There's been a growth of different types of active air samplers. So active being that there is a pump that is pulling air through some sort of material, a filter or media, where then that media or filter then can be analyzed for viral contents. There are, however, challenges to using these type of matrices for looking at airborne transmission, as these units tend to be quite large because there's a pump and battery and filter inside, so it requires a power source as well as it being located then at a fixed location. The pump generates quite a bit of sound, so thinking about the types of environments that it can be placed in that can accommodate that level of noise. And in general, they tend to be quite expensive. So the number of places where monitoring can be done is also challenged. So with that, we started thinking about how can we modify these types of approaches to be accessible on a personal scale. So thinking about the activities that people are doing, the range of places that they are going, especially as we're relieving the restrictions on where they can go and the number of people that they can interact with. So in response to these requirements, we developed a wearable passive air sampler that looks like this over here, that can be simply worn close to the airway breathing area on the clip of your shirt there, and requires no power because it has no power, is completely silent, and is also low cost, so it can be scalable. And we call this clip the Fresh Air Clip. So with this type of personalized air monitoring, we can now provide early warning system for risk of transmission that is specific to the wearer. Different placements of these units across different occupational groups can also then provide information on areas of higher risk of exposure, and then also be able to inform the types of infection control measures that can be implemented in those places of concern. So I'll walk through some of the details of this wearable device, the way that we were able to validate and also explore application to different areas, and also how it works. So this wearable device here contains a polymer film inside that we use to collect airborne virus, so more generally even just aerosol in the air. So we first started by demonstrating that these passive sampling tools can be used to collect airborne virus. And then we were able to then develop different methods to extract airborne virus that was collected on these clips, and then be able to have high sensitivity methods to be able to then quantify exposure levels for the number of viral copies that had been deposited on the clip, so we could express that as the RNA copies per each clip of exposure. We realized that the relevancy of just knowing what the deposited number of viruses are on that clip was limited, and we want to then backtrack and say, well, what does that mean in terms of exposure levels in the air? So I'll walk through the methods that we use to then be able to then convert RNA copies collected on a passive sampling device to relate that back into an airborne concentration. So re-express that in terms of cubic meters of air exposure over that wear period. And then finally, I'll highlight some of the results that we did where we had real world deployment of these clips to be able to investigate what airborne concentrations are to SARS-CoV-2 in different environments. So this was an idea for these passive samplers with the application to SARS-CoV-2 that we had very early on. In March 2020, we started thinking about ways that we could expand our technology, and we're thinking of just how we can demonstrate this to a funding organization to get some money for what we thought was really a blue sky idea early on. And to demonstrate this idea, we went to Yale New Haven Hospital, and we were able to put out various passive samplers and collect swabs around COVID positive patient rooms in the ICU. We used a combination of different types. So this is an example here of just a general layout of one of these ICU rooms, and we were able to hang ceiling suspended air samplers right on top of the patient's beds, within about 3 feet of where their pillow would be. And we also put a very small picture frame sampler that contains a polymer sorbent within the picture frame. And we were then able to then have that continuously on their over bed table to see if we were to collect any droplets or aerosols and detect SARS-CoV-2 presence. We did this for about 20 different patient rooms early on in the pandemic, so late March, April 2020, and we're able to quickly identify that we could have detectable SARS-CoV-2 on these, and that was then the basis for a proposal to the National Science Foundation, the NSF, to get rapid funding to further develop this idea. So we then formulated this wearable design and were able to then put a polymer sorbent within this clip attachment. And we then started to then work on how we could then have high sensitivity to be able to extract virus off of that polymer membrane and then have a low detection limit so we could have the ability to go into environments with lower concentration and still be able to detect exposure. We're able to optimize our extraction efficiency, so we had 45% of viral RNA copies extracted off of this clip device, and then we're able to apply digital droplet PCR techniques to have a detection limit of 6 RNA copies that we could detect collected onto the clip. So our next question is how does this clip perform and how do RNA copies interact with the clip itself? So with that, we measured the rate of uptake of aerosol onto this clip design. And we're able to then say the number of cubic meters of air that was taken up onto the clip per hour of being worn. To do this, we simulated indoor spaces. And ideally, we would have been able to go into an indoor space that had a constant amount of known levels of virus that stayed suspended within the air. But as we know, being able to achieve this in a real world setting is impossible. So we created a simulated indoor space within our laboratory. To do this, we had a rotating drum that we constructed. So within the drum, we were able to inject a known size distribution of a surrogate virus. We used a bacteriophage, Vi6, that we injected into a rotating drum. The rotating drum served to create the virus to be suspended for extended periods, and we could then immerse our sampling material inside of this device, and then we're able to look at uptake rates onto our passive media in conjunction with active sampling so we could see what that uptake rate was. So with this, we're able to show that we had a linear rate of uptake of a virus onto our passive media. And we're able to then express that in terms of the cubic meters of air that was then collected on the clip for hours being worn for a known area of sorbent material. This is something that's being done with other types of passive materials for a range of different other substances, from airborne chemicals, from gases, but also different types of fungi to metals and particulate matter components. All of the different types of devices that have been used for passive samplers have had different types of configurations, orientations, airflows. And we were able to show that with the design that we had for this clip, this wearable design, it actually allowed for enhanced uptake of aerosol compared to a number of other devices that have been used in terms of stationary exposure assessment. And that's this blue line that's shown right over here for our wearable clip design in terms of this uptake rates that we're able to achieve compared to other devices. So now that we had a clip that we demonstrated was able to collect airborne SARS-CoV-2, we're able to understand the dynamics of aerosols in relation to how it was taken up to be able to estimate airborne exposure levels. We then developed a workflow for how we could then take a clip being worn within the field all the way down to exposure detection and report back to the wearer. So we could summarize it in 5 steps here, where we had an individual that would wear this clip. They would wear it for a period for our testing for 5 days. It could be shorter in terms of the number of cases during that time frame if there were an abundance of potential exposure to airborne virus. Following the wear period, it was then sent back for analysis, where we would extract the amounts of viral material from the clip. And then we would be able to then use the digital droplet PCR to be able to detect any copies of SARS-CoV-2. And then we had developed then a report back tool that we could then send immediately back to participants to determine if there was exposure, and then also give proactive guidance in terms of what response should be for further testing, isolation, or other proactive means for intervention at their workplace. We were able to test this device in early 2021 in a number of different high-risk environments, workplaces, where we gave the clip to be worn for 5 days during work shifts. We gave these to restaurant servers, to clinical and non-clinical staff within healthcare environments, different community members as a background, as well as other community groups. And primarily, we were working with some homeless shelters within the Connecticut area. Given the number of cases that were reported in these. In total, we had 62 participants that we had wear the clips, and were able to then also pair that with mask mandates and average estimated SARS-CoV-2 case levels during that day. Overall, we were able to find an 8% detection of SARS-CoV-2 across our study population, and shown here in the violin plots are the distribution of exposure levels. So this is a quantitative exposure that we were able to get with our PCR detection, showing the number of cases above our lower limit of detection of 6 RNA cases per clip. You can see that the highest levels were detected within restaurant servers, and we also had the greatest number of cases that were detected within this population as well. Overall, we found that levels that were detectable using the clip ranged from 4 to about 110 RNA copies per cubic meter of air. This pairs well with other assessments of airborne SARS-CoV-2 exposure, and that's shown here within these bar graphs at the bottom, where they've used stationary monitoring tools to be able to evaluate exposures in various settings. So this was all very exciting that we were able to now have a tool that we could detect airborne SARS-CoV-2, and now we're moving on to evaluating further use within this tool. And we're currently evaluating the association between airborne transmission and then infection. We're doing this within a number of different daycare and early childhood learning centers within the New Haven, Connecticut area, and doing longitudinal exposure assessment with 100 children and teachers, and pairing that with saliva testing using the saliva direct method that was also developed at the Yale School of Public Health. And with this, we hope that we'll be able to demonstrate if there's a real link between exposure to airborne SARS-CoV-2 and COVID infection. And hopefully we'll be able to identify if there's a difference between the level of exposure and the risk for infection. Within that, we're also looking at how we can expand the panel of virus that we're measuring and use this as a more comprehensive platform for viral exposure assessments. So we've now been able to demonstrate applicability to a range of other viruses, and as well being able to pair that with all the other airborne chemical monitoring that we're doing with the same type of polymer membrane technologies. So hopefully this will be a technology that we'll be able to have a much more long-lasting effect beyond the immediate concerns of the COVID pandemic. And with that, I'll wrap up. And just as the previous speaker noted, with a very strong team to support all this work, I also had a very strong team that I was fortunate to work with, a very strong interdisciplinary team from the School of Public Health, where I am based, together with the School of Engineering, and numerous members from the School of Medicine and the Yale New Haven Hospital. All of the results that I've described today were published in early January, so I will leave you with this manuscript, and I'd be more than happy to share a PDF of it together with my email if there's any other questions.
Thank you so much, Dr. Pollitt. Phenomenal work, novel. Like the previous speaker, it's just so exciting to have, you share this amazing work with us. And I just might ask a question before we go to the panel. I might ask two questions if that's okay for you, and then we go to the panel discussion, and then I'll refer to a couple of questions in the chat box. And, as an occupational hygienist, kind of we're used to seeing testing done on these kind of absorbent materials where, a particular chemical is injected onto the sorbent material, and then it's extracted. So we know how much is going on there. It's quite easy to see, that it's actually, we look at desorption efficiency and a number of different things there. And I kind of don't really understand how you can do that with a virus. I'm just wondering if you kind of might like just explain that a little bit more. And the second thing is, there's a big focus on aerosol generating medical procedures. It seemed to be from intubation, that's where the higher exposures were. But, I guess if you think about singing, talking, coughing, breathing, aerosol generating behaviors, are you seeing any differences, like with the monitoring that you're doing? Have you looked at, say, corridors, for example, in healthcare institutions and that? So I just wondered if you mind addressing those two, and then we'll just revert back to the chat box and then to the panel discussion.
So I'll comment on the second question first. So we were very interested in the aerosol generating procedures, and we had a number of the healthcare clinicians wear the clips while they were doing intubations and other aerosol generating procedures early on in the pandemic. The locations for which many of these procedures were performed were in environments with high air exchange. And surprisingly, we didn't necessarily detect levels on the clips from these specific events. So that was a large motivation to start considering many of the ventilation related and building parameters in relation to exposures. That said, it may have just also been that the placements of the device relative to the procedure and the technique just may have not captured any droplets or aerosols that may have been present. We haven't placed them specifically at stationary locations to look at, say, corridor-related exposures where there may be poor ventilation, but could certainly be done within the future for areas of interest. Your first question was related to extraction efficiencies. Could you perhaps just restate the specific question you had for that?
Yeah, I mean, the passive monitor is actually catching viruses in the air. Is that right? And it's passive, so it's not active. So it's basically whatever's floating around gets stuck onto the absorbent material. I'm just trying to understand, like with an organic, if we measure an organic vapor, for example, you can inject the chemical onto the sorbent material and then extract that, and then you've got a very good understanding of the concentration because you know the mass that you're putting onto it. And I kind of don't understand how that would work with a virus, because you can't get a standard aliquot or aliquot with virus, and I'm just wondering, like, how maybe I need to read a bit more and understand that a bit more carefully.
No, that's a great question. So these were all considerations that we were thinking through when we were developing the methods for the clip. And we used various approaches to be able to look at that extraction efficiency, which we thought on first pass would be a fairly easy protocol, and ended up consuming far more of our time than we had originally expected. We were working with a surrogate virus, Phi6, that we were able to prepare within synthetic saliva. And we were able to then inject on a known concentration of viral copies that we had previously quantified, and then look at how our extraction protocol was able to remove the known concentration that had been deposited on. Similarly, for when we were looking at airborne uptake within that rotating drum setup that I had shown, we had a known concentration of Phi6 that were injected, that were aerosolized within the drum. We then were able to then look at the concentrations that were extracted off of our passive sorbents in parallel with the number of copies that we were collecting onto an active sampler, where we had a known volume of air going through a gelatin filter. And together, by comparing the passive sampler uptake versus the active sampling uptake with the known concentration of air, that's how we were able to then develop those uptake rates that I presented.
Great, thank you very much. That's wonderful. It's really whetted my appetite, to hearing you present this information. I really want to try and learn a lot more. I'm sure that people will want to learn a lot more too. So I just want to now refer to the chat window. And what I might do is I might actually, there's a couple of people that have asked questions, and rather than me repeat what they've asked, if they don't mind, maybe they can ask them themselves to the panel. The first one is Lawrence Virtue. Did you want to unmute yourself and ask the question, Lawrence? If you can.
How am I doing, Kevin?
Yes, I can hear you. We can hear
you. You can hear me? I have to actually go back to, I have several questions posted, so I certainly don't want to dominate what's going on. I'd actually, for our first presenter, in terms of severity of infection, would hospital PCR testing be more accurate and more helpful than community testing? I also asked, how does PHAC report cases and mortality to World Health Organization? That has an obvious bearing on how we see the international situation. And I made a short comment. Doctor, you point out that despite the declining trend, the international case and mortality rate is still higher than ever. We still publicly in Canada and the United States have the myth perpetration that everything's going to be okay. So I think that question is relevant, or that comment is relevant to two of the panelists who made comments about that. Thanks, Kevin.
Okay, so maybe over to you, Goshi. And I don't know if did you want to add to that, Dr. McKenzie?
Yes, thank you. Thank you for the question. So how, first, I don't know how Public Health Agency of Canada reports cases to WHO, so I cannot answer this. Whether I think testing community is important, because then we know what's going on. Now we test mostly PCR test the people in hospital. So we are missing the information about asymptomatic or just not severe cases and how much we have infections. So with the capacity, and we still have big capacity, so I think we could still continue doing community testing. And for the severity of COVID and Omicron, so there are two important things that we are focused on. Okay, or the narrative is focusing now on case fatality ratio. So how much probable a person is to die from getting when the person is infected. But individual risk is combination of probability of getting infected times probability of having severe outcomes from infection. And because of this, even in CFR, so case fatality ratio, is approaching, but it didn't approach yet the influenza rate. But because we have so much transmission, because R value of Omicron is so high and so much higher than R value of influenza, that's why a lot of people are dying. And also in Canada, so I could just quickly compare the numbers. In the last fifth wave, which we are still in, 6,500, more than 6,500 Canadians died. From influenza in 2018-2019 season, 224 people died. So those numbers are like, even if part of the 6,500 deaths are with COVID, not from COVID, even if 30%, then we are down to 4,000. It's still more than 224. So yeah, COVID is still a dangerous disease, and because it spreads so fast, and because it's not regulated, we cannot count that we will have just one wave or one double hump wave per year, because R value is so high. With influenza, we are so lucky that the R value is just a little bit above 1, and the season can dump R value below 1, and then the wave goes down. And we wait till the next season when the colder weather makes it go up again. But if influenza wouldn't have such seasonality, if R value would be higher, probably we would have to treat even influenza much more serious, because it would spread without control. There would be no this natural control of dampening it down. But anyway, Omicron is now killed more Canadians than influenza, so it's still dangerous.
Yeah, it should be taken seriously. I mean, dangerous is a word that is, it should be taken seriously. Absolutely. I think philosophically there might be a difference here. I think, as Michael Osterer, the very good American epidemiologist, said, it's a bit like trying to stop the wind of coronaviral infections, and so I get a bit anxious thinking that we're going to just stop it forever, and we're going to maintain these, and just because halting its spread, especially given how very effective it is, I think will take constant vigilance on all our parts, and it's a vigilance that clearly is not being observed elsewhere in the world. And so, irrespective of what happens in Alberta or Ontario, Florida, South Africa, and other countries will almost certainly not adopt that, and therefore, as far as ongoing evolution of the virus, I think it's going to happen on a global basis. I think our thoughts that we're going to that we're going to stop new variants coming because we adhere to standards here might be a bit optimistic. But also, I mean, I don't want to take up all the time, but basically, it won't stop you from getting infected, and the whole idea that the immunizations would stop us from getting infected, in retrospect, is the wrong idea. It's a severe illness, and I do think if you look at the T cell immunity, which really is the key factor here, it is maintained with Omicron, and even BA2. There's a maintenance of T cell immunity. So I think perhaps the glass is half empty for you, and possibly poisoned, and the glass is half full, and it's vodka. And so basically, I think we have two ends of the spectrum as far as our view on it. As a pediatrician, I just know how really non-dangerous it's been compared to RSV, compared to parainfluenza. COVID itself is number 3 or 4 as far as viruses which can harm children. And so when I think about keeping our children safe from infections, SARS-CoV-2 doesn't make it to the top of that list for sure. Anyway, but I'm sure there's a whole spectrum of views with everybody. I'm just a delusional optimist, as my family says.
And you know, it's great to have a balanced perspective on that. That's the great thing about these kind of webinars. And I really like the you know, the way that Garcia presented the risk, looking at probability and infection.
Right.
And probability is something that we do have control over. And, you know, when we go out into the public, you know, how many people are wearing N95s in the public? When you go in a restaurant, do you see air purifiers being used? And, you know, and even the kinds of face coverings that servers are wearing, they're not wearing N95s. There's so much more that can be done to address that probability side of the equation as well. So I might just now refer, the next question was from Zayed. Did you want to unmute yourself, Zayed, and ask the question yourself?
Yes, thanks for the opportunity. My question to Dr. Gasparovich is, she advised that the RO of Omicron is unknown. I've seen some other estimates between 10 and 18, or that is described as similar to measles. I'm just wondering why it's difficult to form a consensus on the R0 of Omicron, please.
Thank you very much for the question. So yeah, the problem with Omicron and challenge with estimating how really what is R0 of it is because, okay, it has transmission advantage over Delta, but the transmission advantage has two components to it. One is intrinsic transmissibility and one is immune evasion. And it's just very challenging to untangle both of them. So if it would be very, very immune evasive, it could still have R0 the same as Delta, but be more had transmission advantage. Or it could be non-immune evasive and have very, very strong R0, very, very high R0. So it's somewhere in between, but it's the best estimate I've seen was that the most sure, like, okay, it's probably more than 7, but how much more than 7? It's still not really clear, super clear cut.
Thanks. If you don't mind, I've seen some statisticians talk about an attack rate, that if there's an event or a home, that the spread of the infection from one person at the event or one member of the home has a higher attack rate than previous variants. Is that a commonly used measure that you see?
I didn't look much at it, but the study by Dr. Saito from Japan showed that it replicates, that Omicron replicates more in upper airways, and that it's more fusogenic and produce more viruses. So then the attack rate might be higher, that an infected person exhales more of it. Did it answer your question? Or?
Yes, it did. Sorry, I went on mute. Kevin, I have a comment that I made during Dr. Gasparovich's presentation. I can sort of turn that comment into a question and make it open to the whole panel.
Sure.
So the comment I made is, when we talk about source control and improving masks towards respirators as source control for the population, I remember the late 70s and the 80s when smoking sections used to be just part of a cafeteria. And experts compared that to urinating and non-urinating sections of a swimming pool. So largely from occupational health to protect the workers in buildings, smoking was either moved outdoors or to a separately ventilated, quote, fishbowl within the cafeteria, for example, to limit secondhand smoke exposure to workers and others. The question I'm going to turn that for is anyone looking at that sort of occupational health or public safety kind of legal pressure to mandate masking or respirators as source control within buildings? And if anyone's interested, I could look into the legal framework that happened in the in the 70s and 80s. I was fairly young at the time, but to see how that was measured and applied to change smoking sections.
It's kind of an interesting question, Zayed. When you talk about legal, you know, this is kind of, we're sharing the science here, and, you know, to think about how we're kind of influencing the legal side of things. Unless the other speakers want to share on that, I don't know if that's kind of an area that we probably, what I can say, and I'm sorry, I'll hand it back to the other speakers in a minute. Lisa Brossu provided a presentation probably close to a year ago now, where she did talk about outward leakage of respirators, you know. So there's a lot of attention on inward leakage, you know, having the proper face fit, but there hasn't been a lot of work done on outward leakage. But she did provide some really useful information on outward leakage. So yeah, it's a very important point that, you know, if we're wearing a face covering, we don't want to be releasing the virus, you know, through the outside of the respirator as well. I don't know if anybody else has any comments on it. Anything here we've talked about?
Sure. And just to clarify, I wasn't looking at leakage from people wearing face coverings. I was looking at whether people wear a face covering or not. And I didn't want to take it too far legal. I just wanted to ask about the movement of scientific information into implementation through legal means. Okay, thanks.
It gets a bit tricky insofar as Crystal, you're trapping the viral particles on the mask and getting a sense of exposure. A second question, which is so much tougher to do, is to actually take those viral particles and do the actual culturing to see the rate of sort of infectious particles. I'm not sure, did you guys take that next step? Often in my experience, the next step shows it can be quite hard to find live viruses, but did you guys have experience with that at all, Crystal?
Yeah, so I'll answer that, and then I'll go back to the original question. So a lot of the techniques or the motivation for using the passive sampling was to, in part, to also address the inability to test for viability with the commonly used active air samplers. The rate at which they were impinging or collecting virus onto a surface or into an aqueous media just completely destroyed the ability to test for viability at those flow rates. Right. And that was concerning with the initial studies that were going on, because they couldn't demonstrate viability for that reason, and such a pushback on being able to explore the possibility of airborne transmission early on. So the passive sampling does allow for testing viability, because you are just having that primarily deposition on the sorbent. Yep. That says, we haven't then made that step to look at viability. We've taken the different direction that we want to then look at infection cases in relation to exposure. Yeah. However, we could, in parallel, and this might be a point of potential collaboration, is if you were interested in looking at that viability of a parallel collected sampling material.
Great. Okay.
But going back to the original question, I think a lot of the issues relating to just the masking issues has come down to, can you be able to measure and detect where you have exposure to SARS-CoV-2? And the challenges with airborne testing, because it is a respiratory virus, has just been so challenged with not having these stationary samplers that need to be plugged in and set in a room at the ideal location to be able to demonstrate that. So I'm hopeful as we can have more wearable technologies and more measurements available to scale, that's going to allow for enhanced understanding of risk.
Mm-hmm. And if I can just add to that, you know, from an occupational hygienist perspective, you really want to do personal exposure monitoring. You want to measure what the person's actually breathing in. And if you put a fixed monitor out there, it's very hard to sort of figure out, well, what is the person exposed to? So that's, I guess that's the value of those passive samplers there. Crystal, I just referred to a question here in the chat box for Marianne Levitsky. She said she had to step away. I don't know if she's still here or she's come back. I don't think so.
Yeah, I'm
okay.
here. I can
Do you want to answer
Thanks.
the question?
Thank you. Thanks so much. Those great presentations, everyone. My question has to do with whether we should take approaches like the US CDC is now doing, where they establish different risk levels and tie prevention measures, in this case, masking recommendations, to community risk levels as measured by incidence rate, somewhat similar to what the province of Ontario did way back when they had red, green, etc. Threshold levels. So what do you think of that? I'm thinking, especially Dr. Gasparovich and Dr. McKenzie, I'd be really interested if you think wastewater signals could be used that way, and what would be some threshold levels, and the same thing with what Dr. Gasparovich was talking about in terms of it may be R levels or incidence level.
Sorry, yeah, that's a tough one. In a perfect world, having a certain level and saying we think X number of people are infected within this long-term care facility or within this small town, and therefore we need to do an alert level of X or Y, and this is a hard risk value. Because of the noisiness of the data, et cetera, we are not there. So it's a day-to-day trend monitoring as much as anything. And as I say, I think the protein approach may be better than the RNA approach, but for sure helping with a sort of community-wide alert levels and just whether or not we're heading in the wrong direction or not. Trend monitoring, as with so much, not a hard binary, we're in an outbreak or not. So it's great adjunct data, I think. And Garcia, what are your thoughts?
Yeah, so I think it's great. It's important how we set up the thresholds. So for me, a great example of very scientific approach to implementing measure or relaxing measures with the numbers and thresholds is Australia in Melbourne, in Victoria State, when they've been going down from their second wave in August-September 2020. And they used modelers really calculated what is the probability if they relax restrictions at a certain level. So they knew that they could open schools when they have a little bit more than 5 daily new cases during 2 weeks. And they did it, and they had just 3% chances of having third wave then. But if they would reopen at 20 daily cases per day, they had 60% chances of having the third wave. So they followed it, and they gradually reopened at the really safe level calculated by the models, calculating the probability of increasing the transmission. But other jurisdictions did it a little bit, and they set up the thresholds, but the thresholds were too high for certain things, or too low. Just acting too late, or for example, putting mask mandates only when the threshold is really, really high and there is already high community spread, instead of putting mask mandates a little bit lower when actually the spread can be stopped or prevented. Yeah, so for me, it would be that, like, using, for example, as for mask mandates, like, we could drop them when there is zero community transmission in a given region, because we make the spread. So if now we drop mask mandates, we can be almost sure that soon the transmission will increase. So, like, COVID is not like an earthquake that just comes and goes, and then we clean up after this, but we are making it. So whenever we relax, we increase the spread.
Great, thank you.
Thanks for the question, Marianne, and thanks for a great response to the panel there. I did see Zaya did put another question in here. It was talking about, was kind of really targeted towards Crystal, and looking at carbon dioxide. The carbon dioxide measurement is kind of an interesting thing. You know, if you've got filters, high efficiency filters like MERV 13 plus filters or portable air filters, you may be cleaning the air, but the CO2 may be going up. So it's a kind of an indicator of fresh air. It's like a bit of a screen, if you like. But so Zoe had asked if you'd actually looked at, or are you planning on looking at sort of correlating with CO2, I think, moving forward, with the testing.
Yeah, it's a great question. So at the moment we have not, but we have collected samples and paired building characteristics of individuals that have been working in different environments to do that type of testing. So we've been working with different healthcare facilities across New Haven. We're at about 125 people that we've been working at a range of different outpatient clinics for. And have all that information about CO2 levels and ventilation to be able to then pair where we have had detection of SARS-CoV-2 for personal exposure and those. And we're also building on that, starting on a new study looking at in general respiratory hygiene procedures in healthcare settings in relation to exposure and then also infection rates. So we'll be able to provide more insight soon.
Thanks, Dr. Pollard. I guess it's about collecting all of the information, all of the controls in place at the same time, a bit like a randomized control trial for respirators versus surgical masks. With respirators, you need to make sure that there's fit testing, that people are trained, that there's continuous wearing to do a proper RCT. So just on that, we've got 8 minutes left, and what I might do is just maybe put it to our audience. If anybody's got a burning question they want to ask, you'll see down the bottom of your monitor, there's a little hand there. If you want to, I might just give you a minute or 30 seconds, just if you want to raise your hand to ask a question, or if you want to say something, please do so. And then after that, what I might do is just circulate through all our speakers, and you might want to have some closing comments from this webinar. And even Val, if you want to unmute yourself and show yourself, you might have a final comment too. So I just see if there's any hands up at the moment. I can't see any hands up. No. Oh.
I could ask a question about I asked one, I think, at the beginning with respect to the wastewater, but a question for everyone, I guess, is because this is about the occupational impact of COVID, but mostly it's about prevention. We're trying to figure out how does the research or the modeling and the surveillance, how can we translate that for prevention and how our workplaces and workers to judge, I guess, and manage in the next weeks and months. And I guess, do you have any insights on that? So that's a question to each of you from your where you are right now and the information that you've presented today. How best do you think workers and workplaces can prevent transmission and protect the health of themselves and their families?
As the least qualified, I might just leap in and just say, in keeping with Crystal, I think it's respiration. I think it's we talked about aerosol, but I think the balance of the evidence is talking about droplets within 3 to 6 feet. And so I do worry a bit that focuses on surface cleaning or more distant, maybe a distraction. I think using devices such as Crystal's and using our common sense about that kind of exposure is really where our laser-like focus needs to go, using things like wastewater as adjuncts. And I think people in our realm need to talk to people, Val and Kevin, in your realm a bit more. We're sort of maybe a bit siloed as well. But yeah, that would be my quick thought. I don't know, Crystal and the others.
I don't know, Crystal or Goju. It looks like we've lost Kevin, so we'll just keep going till he can come back in. Oh, there you are, Kevin. Great.
Yeah, I was just going to text you, Val, to tell you my internet's gone down, but I'm back up. It's great, thanks.
So Alec just made a comment around droplets. That's actually a bit of a red flag around here, since we're very much.
Sorry, I apologize.
No, it's good though, because it's good to understand the understanding, I guess, that, and it still remains contentious, although certainly there's a lot of evidence around aerosol transmission, which isn't this event, but we have had others, and we will have more. But maybe Crystal or Goja want to answer my question around prevention, but also if you have anything to comment with respect to.
I didn't mean to pick that scab open. I apologize.
No,
No, I
it's
think
okay.
it's really, I agree. It's really important. You know, there's quite a few of us on the call very passionate about, you know, aerosol transmission, hence the Aerosol Transmission Coalition.
Oh, it happens for sure, but I just a proportion. Anyway, sorry.
No, it's a fair question, and it is definitely out there. So we don't want to suppress that question, right? It's so how do we engage on that? I don't know if Crystal or Goja want to tune in or.
Sure, I can expand on that. So with the results that I showed you from even the first round of testing that we published, if you look at the places that have the highest levels of SARS-CoV-2, it's the places where you did not have the mask use in the restaurants with the indoor dining. And even though mask mandates are lifting, the need for that continued use, especially within the high risk settings, many of those being occupational, I think will still warrant use. And it's certainly something that I will continue to wear well beyond COVID. So I'll leave it at that.
Yeah, thanks. Goja, Goja?
I think with this question of short range transmission, like within 2 or 3 meters, it can also be explained by aerosols, because people have the largest concentration of aerosols around them, right? So then it can be, if I'm infected, somebody is close to me, and I exhale a lot of aerosols, they are more here than farther away. So it can also, right? But yeah, and I'm. Yeah, but with workplaces, and that's what I recommend all my friends and people who have day homes and so on, to keep as much like air filtration as they can and ventilate and use good masks. And especially I have many friends, maybe Zero COVID Canada and such organization, naturally people who cannot live with COVID go to these groups, because people who are immunocompromised or whose somebody in family is immunocompromised, they won't have normal life unless COVID is stopped, basically. And it's quite a big group of people. And for all of them, I would recommend wearing as strong respirators as possible to prevent infection. And in workplaces, also wearing, like other people who are not immunocompromised could wear as good respirators as possible. And we have CO2 monitors. We have PM, some air purifiers, at least in Europe, have those. They can measure the particulate in the room. So we can open the window, reduce CO2 level, and then filtrate and reduce particulate level, and then just be safer.
Great, thanks. Just to add to that too, so the presentation that was delivered on the first, it was about being mask smart, that a few of us pulled together, volunteers that is, and you know, a link has been put to that in the chat box, and you know, you might want to have a look at it. And we're talking about more mask using, or sort of respirators being used for the public, including, you know, for people instructing or doing yoga, for school children. So it's probably a useful resource there for just for public as well. I think we're probably drawing a close. So I just, is there any final comments from anyone? I just before the final comment, I just really want to thank Dr. Gosia Gasparowicz, Dr. Alex McKenzie, and Dr. Crystal Pollitt. We really value your time. We know how much energy that takes to do this. So on behalf of OCO, thanks very much. So any final comments from anybody?
It was fun. Thank you very much.
Yeah, thank you very much. I learned a lot from Alex and Crystal presentations.
Great.
That was really fascinating. So it was nice to.
Gosia, you and I can stay on and we can argue, okay? No,
Okay.
Do that.
You win. You win. I don't know. You've got data. Thanks very much, everyone.
Yeah.
Thank you.
Okay, bye.
Thank you.
Bye-bye.
Thanks, everybody. We are planning another event probably on March 25th, and we'll email with the details probably next week, and also be able to tell you when the videos are online. I did put in the chat that they will be on Facebook right away, because when we broadcast live, it renders the video right away if anybody wants to share with friends or family or colleagues. So thanks again to the speakers, to Gosha and Crystal and Alec and Kevin for hosting. It was great. And we'll see everybody in a few weeks, and keep healthy and safe as you're able. I guess I'll turn it over to you, Kevin, to say goodbye.
Yeah, I just want to acknowledge Alec Farquhar too. I know a few people have dropped out, but Alec's been coordinating this aerosol coalition. And I always think to myself, no, I've got to acknowledge Alec, and also Stefan Biladu. But yes, these people that are providing great leadership and helping us work together like this. So thanks, Alec, if you're still on the call. Thank you.
Bye, everybody.